Start now.
Hello, everyone. A warm welcome to you all. I'm Dr. Mythri Shankar, Assistant Professor in Nephrology from Institute of Nephrology, Bengaluru, India. I'm also the Program Director of Nephrology Education Collective. We're all well aware that clinical application of biomarkers is an integral component of transplant care. The current commonly used biomarkers are serum creatinine, donor-specific antibodies, urine analysis, urine protein estimation, and the gold standard is kidney biopsy. Clinicians and scientists alike are in search of better and more predictive biomarkers. The science behind recent biomarker discovery spans across multiple molecular biologic disciplines, including transcriptomics, proteomics, and metabolomics. Novel biomarker uses to guide the diagnosis and management of transplant-related outcomes is a promising area of research. To shed more light on this, we have two eminent speakers, and it is indeed my honor and privilege to introduce them to you all today. Dr. Mariam Priya Alexander is a faculty pathologist in the Division of Anatomic Pathology and Laboratory Medicine at Mayo Clinic, Rochester. She's a professor of pathology at the Mayo Clinic College of Medicine and Mayo Graduate School in the USA. Dr. Alexander's research has focused on both native and allograft renal pathology. Her work has involved the discovery of DNA JB9 protein as a biomarker for fibrillary glomerulonephritis and pathology of the aging kidney. Her most recent work has focused on using imaging mass cytometry in evaluating COVID-19 acute kidney injury and renal allografts. A warm welcome to you, madam. We also have with us today Dr. Taner. Dr. Taner is a professor of surgery and consultant in immunology at Mayo Clinic, Rochester. He's a chair of the Division of Transplantation Surgery and the surgical director of liver transplantation of both the adult and pediatric programs at the same institution. His clinical practice involves liver transplantation, living donor hepatectomies, and nephrectomies. His research focuses on liver transplant immunobiology, investigating the interaction between the liver allografts and the host immune responses. A warm welcome to you, sir. We can now start the video recording.
Thank you so much for this invitation to the ISOT Edu Connect. We're very grateful to be able to present our research data. Our title for the talk is Recent Advances in Exploring the Immune Landscape of Renal Allografts. And this is truly a novel journey in exploring the possibility of novel biomarkers for evaluating allograft biopsies. I'm Dr. Alexander. I'm a professor of pathology at Mayo Clinic, and I'm participating with Dr. Taner, who's professor of surgery and transplant immunologist at Mayo Clinic. The brief outline of this talk is to have a quick glimpse of how artificial intelligence impacts medicine and specifically pathology and renal pathology. Artificial intelligence has actually had a significant role to play in medicine and in other spheres of financial and social aspects, but it's had a role to play in medicine as early and earlier than 2019. And here we see how Mayo Clinic has invested a significant amount of its efforts in developing artificial intelligence in various aspects of medicine. And as early as 2019, it was involved in screening for cardiac abnormalities from atrial fibrillation. But how is artificial intelligence relevant to us? It's a branch of computer science that deals with the simulation of intelligent behavior in computers And one branch of artificial intelligence is machine learning. This is a branch of artificial intelligence in which the computer software learns to perform a task by being exposed to representative data. Machine learning is definitely a complex topic, and this is a field for computational biologists. And as a pathologist, I do not claim to have knowledge in the computational biology aspects. However, a simplistic way of looking at machine learning as it applies to medicine and in pathology is to understand what are the functions of a machine learning system and how can it help us. So there are descriptive machine learning systems that help explain what is happening. They look at the data and are able to compute and explain the data to explain what's happened. It could be predictive, where it predicts what will happen. Using the data, it predicts what will happen with the given data. And it can be prescriptive, meaning that the system will use the data available to make suggestions about what action one can take at the current time with the given background data. Now, there are several subcategories of machine learning, but the ones we look at are supervised machine learning models, where you look at labeled data sets and the machine is taught on labeled data sets. And this grows over time as it gets more and more accurately labeled data. The machine is able to accurately predict data. This is very dependent on the labeling of data, and therefore it's very critical that effort is made to label data accurately. Unsupervised machine learning is another pattern of machine learning where the machine computes unlabeled data and the machine is able to find patterns or trends that people aren't explicitly looking for. And this is a very important aspect where it provides us layers of data that as humans we had not previously thought about. Now, machine learning has taken a hold on several aspects of medicine, but we have seen that there are groups, particularly out of Paris, that have done extensive multi-center studies and validation studies to look at how data, whether it's the clinical laboratory data, the immunological data, the histological findings on a biopsy, how can all of this data together be used to predict renal allograft loss? But how does artificial intelligence apply to renal pathology? This is what is our scope of understanding, and this is the scope of today's talk. So a lot of today's data, a lot of where we are heading to in renal pathology and other aspects of pathology is exploiting digital pathology. So what is digital pathology? It's really a blanket term that encompasses tools and systems that are used to digitize pathology slides and associated metadata, their storage, their review, their analysis, and also a very important aspect of digital pathology is thinking about the infrastructure for this field. There are several advantages to digital pathology. Today, we are starting to use it at Mayo Clinic. We've already started using it in regular diagnostic work. It's an excellent tool for teaching. It's also had a significant role to play in research, and it's going to have a significant role to play in research. And there are also logistical aspects of digital pathology that will enhance our efficiency going forward. So in the role of kidney pathology, how do we want to look at artificial intelligence? Well, there are two broad ways of looking at artificial intelligence. One is as an enabler to improve your efficiency. So any tool that helps pathologists in accomplishing specific tasks with fewer manual efforts, higher efficiency, and a better performance is one aim of AI in kidney pathology. But another important aspect of artificial intelligence in kidney pathology is what are the new capabilities of artificial intelligence that are applied and that are unscalable with conventional techniques. And that is where we will probably spend more time. So here are just few examples of how we have worked at Mayo Clinic. This is a collaborative study between Mayo Clinic Transplant and the Radboud University, where we've looked at whole scanned images of renal biopsies, and these are transplant biopsies, and we've looked at how a convolutional neural network can be used to segment renal tissue and identify microstructural components such as the glomeruli, the tubules, and the interstitium. And we can see here that this has had high success when applied both to transplant biopsies from one center, validated in a second center, and then actually we show how it's useful when applied to a nephrectomy section. So this is using the UNet convolutional neural network system and training the computer to be able to identify microstructural components such as the glomeruli. And you can see that what has been trained on needle biopsies can be applied to nephrectomy sections, and the computer is able to accurately predict microstructures. Now, this is a great use of artificial intelligence, and it significantly improves the efficiency for the pathologist. This is another example of the use of artificial intelligence, where we are now focusing beyond identifying normal microstructural components to training a multi-layered segmentation model to pick up more chronic changes such as global glomerulosclerosis, interstitial fibrosis, arteriosclerosis. And this also, you can understand, has significant role in improving the efficiency of the pathologist. There are artificial intelligence tools that have been applied to predicting the kidney biopsy diagnosis. And this is a Nature Medicine publication from Alex Lupi and the Paris Transplant Group, where they have incorporated histology, ancillary tools such as C4D staining, the immunological parameters such as DSA, and other clinical data to be able to come up with an algorithm that incorporates the data to predict the diagnosis of a kidney biopsy. So where are we now? We want to look at how we can explore kidney biopsies in a more novel fashion to identify, gain insights that are not provided by conventional techniques. So for this purpose, we, Dr. Tanner and I, have focused largely on allograft biopsies. And for this, we come back to why did we do this? Well, the allograft biopsy has had the advantage of a very standardized evaluation system called the BAMF system. And it's named after where the first meeting took place in Banff, Canada in 1991, where a group of pathologists, surgeons, nephrologists, and immunologists, and among others, got together to develop a standardized criteria for evaluating renal allograft biopsies. The purpose was for standardized diagnostic techniques, to provide a standard baseline for trials so that there is a standardized nomenclature, and to allow a more unified way of evaluating renal allograft biopsies. This is an excellent system. It's widely used today, but we can see in this publication from 1991 to 2021, every 2 years, based on validated data that improves on the existing protocols, how the BAMF classification system, which originally began just as a histological evaluation, has moved forward. And you can see that due to lack of information that one can get from a standard histological section with just H&E and standard stains, there was a need to adopt molecular diagnostic tools to improve the information that one could gather from allograft biopsies. And today, at 2024, we see that artificial intelligence has already taken a significant role in evaluating renal allograft biopsies. There are digital pathology techniques, and there are several molecular tools that have been adopted into the BAMF classification. So why is there a need for this? Well, allograft biopsy evaluation has had significant improvement, but we still see that despite all the improvements in immunosuppression and novel techniques and innovative aspects of medicine that are applied to kidney transplantation, graft failure remains a problem. And one of the, this is a study out of Mayo Clinic where we see that one of the big causes of graft failure after kidney transplantation is immune injury. And immune injury is one of the largest components of causing graft failure, but other causes of immune injury, as seen here, BK nephropathy, can contribute to graft loss. And therefore, for us to move forward, we need to investigate immune injuries in graft analysis to finally improve patient outcome. Now, if you take alloimmune injury, we look at it in a very binary fashion where we say antibody-mediated rejection, and we go with antibody-mediated rejection as being characterized by microvascular inflammation as seen here, or T-cell mediated rejection where you see tubulitis as seen here with interstitial inflammation. Now, this is a classification that has held good for years and remains an important way of approaching this. But is it as simple as what you see on histology, or are there more layers to this? There's another big area that's a challenge, and that's inflammation in areas of interstitial fibrosis and tubular atrophy. And that is characterized by this inflammation in scarred areas. And one knows that this is a non-specific pattern of injury and can be seen in various diagnostic conditions. So here I show you a core of biopsy, which looks relatively unremarkable. Another core taken at the same time shows you significant inflammation in these areas of scarring. And one can see tubulitis here, you can see a plasma cell here, and you can see a lot of edema and inflammation close to atrophic tubules. And this is IFTA. Now, this is a non-specific pattern of injury. It can be expression of chronic active T-cell mediated rejection, could be BK nephropathy, it could be chronic pyelonephritis, it could be reflux nephropathy, and that is perhaps just the tip of the iceberg. So one can see that this is a non-specific diagnosis. And just to illustrate that, take a look here, the inflammation, this could be T-cell mediated rejection, or it could be chronic pyelonephritis. But if you look here, there's a smudgy cell, a single smudgy cell, and here you see the viral cytopathic changes with enlarged nuclei. And when you do the PCR-ish for BK, that's positive, concluding that this inflammation in this area is from BK nephropathy. Now, the treatment is very different with these different diagnoses, and one can see the importance of accuracy in diagnosis. Here's another example of inflammation in areas of interstitial fibrosis and tubular atrophy, and one has to really search carefully, and one sees a few leukocyte casts, suggesting that this could be chronic active pyelonephritis. But here again, one needs to correlate it with clinical information, with radiological information and culture studies. So truly the pathologist is at a roadblock when it comes to this routine evaluation of pathology. Now, this is the reason why molecular tools have come into play very early in the evaluation of allograft biopsies. And we have seen that with the molecular microscope introduced by Halloran and group, and now more recently with the nanostring BHOT panel with Mengel and Adam in Edmonton. Now, here we have our own Mayo Clinic studies, which have been led by Dr. Taner and Dr. Stigall, where they have evaluated kidney allograft biopsies, exploring the role of bulk transcriptomic studies to see if molecular transcripts can give us better insight into why changes in the kidney allograft. And the results have highlighted that there are important transcripts that yield much more information than what one sees at the regular histological level with routine stains that are employed. But one of the challenges, while these are certainly have several advantages, which include reclassifying of disease states, a better understanding of biology, a truly improved understanding of druggable targets and prediction of outcomes, challenges with the bulk transcriptomic studies are that often you need a separate core of biopsy to be taken at the time. You need a separate stabilizing agent, and often these tests have to be done in a centralized area. So this need to take a separate core and not be able to use archival material has been overcome with the nanostring BHOT technology, where you can actually use archived formalin-fixed paraffin-embedded tissue and are able to analyze allograft biopsies. The disadvantage of this technique is that you have to take tissue scrolls, 10 micron thickness of tissue scrolls to analyze this. And in addition to the fact that you use a lot of tissue, you also have the disadvantage that you lose the anatomical localization or you don't have spatial data. So these are the challenges, and one of the biggest challenges, spatial dimensionality is lost. So this is where we move into the tools that we have now used, which is digital spatial imaging tools. And this can be exploiting analysis of allograft biopsies looking at DNA-based material, which is through codex, or RNA-based spatial transcriptomics. And the technique that we have used and that we have found very interesting, which we'd like to share with you, is imaging mass cytometry, which is based on a more spatial analysis of proteomic nature. So very quickly, for the DNA-based analysis, the tools, the technique is involving complementary fluorescently labeled DNA probes. The advantage is that you can see up to 60 markers in situ. And this involves multiple cycles of reaction where you stain a certain number of antibodies, then you strip and rehybridize the tissue with a new set of probes, and then finally analyze the tissue. And again, complex analysis is involved in accurately analyzing this data. Similarly, this is the GeoMix digital spatial profiling tool from NanoString, and this makes use of RNA probes and you get spatial transcriptomic data. This is also a very novel and interesting tool. But today we are going to focus on this technique that we have used called imaging mass cytometry. Imaging mass cytometry is more recently developed. It allows you to analyze single cells in a spatially resolved manner. It integrates multiple data analysis of up to 40 protein markers. It allows you to correlate individual marker expressions with one another and with their interaction in a spatial context. And it allows you to explore physiology and pathological basis of disease. For this, first you need to select a monoclonal antibody panel that suits your specific need. This then has to be validated on normal tissue. And then the very important step for imaging mass cytometry is that these immunohistochemical markers have to be conjugated with rare earth metals. It is this metal tagging that has a significant role to play in the unique nature of this analysis. So the advantage also is that you can use archived tissue of even up to 10 years or more. So you can analyze very significant cohorts. You can do multiple trials from different centers and validate your data. Retrospective data analysis can be done. Spatial orientation is not lost. And minute lesions such as endothelialitis, for example, is not lost, or single viral inclusions are not lost. What you do is you design your panel, you then stain it with the metal tagged antibodies, and you use a hyperion imaging system. And then using UV light, you choose the regions of interest and you ablate the tissue. And this exploits the metal tagged antibody, which is then vaporized, and based on its mass spectrometric properties, you are able to acquire the data in the specific regions of interest that you have just ablated. And this data is then acquired through different software and analyzed with a complex computational biology tool where you need very sophisticated analysts, and that is definitely an important thing to stress in this paper. Now, imaging mass cytometry has been widely used. It's extensively used in cancer, in autoimmune diseases such as type 1 diabetes, in multiple sclerosis, and extensively has been evaluated in hematological diseases. This is an example of how it's been used in type 1 diabetes, where imaging mass cytometry has been applied to biopsies of patients who are non-diabetic, who have type 1 diabetes at the time of onset or long-standing duration of type 1 diabetes. And using immune panels and structural markers, they've been able to say that preceding the onset of type 1 diabetes, there's a loss of beta cell markers, which precedes the actual evaluation and ability to detect beta cell destruction. And there is a role to play of immune cells, cytotoxic and helper T cells. So that is an important information that's been gathered from using imaging mass cytometry. This is another example of how single cell pathology has been exploited in breast cancer, where the ability to evaluate cancer interaction with immune markers and stromal cells has really advanced our understanding beyond the traditional clinical and biological prognostic markers and beyond the traditional hormone markers for evaluating breast pathology. And we can see the importance of stromal markers, basal cytokeratin, and we can see how outcome has an improved prediction just looking at it in a novel way, where we can see that you can differentiate outcomes much more than with the just traditional clinical subgroups when you look at it in terms of immune-enriched stroma or the presence of basal marker expressions, the absence of cytokeratin markers. And this is just one example. You can see several Nature papers that have used imaging mass cytometry in this fashion. So how has imaging mass cytometry been used to evaluate kidney biopsies? So this is a study that's been come from Yale University, where they have exploited a spectrum of markers, both predominantly structural markers, that have allowed the creation of a 2D kidney atlas. And one can see this is the single core stained by routine histological techniques, and how regions of interest have been selected, and these areas have then been previously stained with a panel of markers. And here is an example of how multiplex labeling allows you to identify glomeruli, proximal tubules, distal tubules, and even further, you can analyze different thick ascending loop of Henle. So in a single section, you now have an atlas that enables you to identify unique segments of the nephron. One can appreciate that that is truly an advance in technology. Not only is that possible, but because of the strength of single cell analysis and the ability for the machine learning to cluster cohorts of cells that are similar, one identifies types of cells that previously have not been known or recognized by researchers. For example, there is a novel cell type of clusters that express both vimentin, aquaporin, and megalin, and certainly needs more exploration. So one can see that this is hypothesis generating in addition to standardized use of the tool. So there's also using imaging mass cytometry to quantify kidney structures and identify novel cell types. In addition, it has been used in lupus nephritis, just as an example of a glomerulonephritis, which has exploited this tool. And what it has done is it's looked at two classes of lupus nephritis, and it highlights, based on this single cell spatial technology, how one can analyze the immune composition in glomeruli that show either a class 2 proliferative lupus nephritis or a class 4 lupus nephritis, and allows you to see the difference in the immune composition, correlating it with the spatial associations. So here we move to our experience. Dr. Tanner and I have worked on at least 4 studies looking at imaging mass cytometry in kidney pathology.
Thanks, Dr. Alexander. So I'll present this part. When we first got interested in this technology, it was at the time of the height of the COVID-19 pandemic. And as we were learning this technology, we wanted to use this to interrogate the lymphocytic infiltrates in kidneys that have been found in patients who died of COVID-19. with histologic evaluation, we were seeing a lot of infiltrates, but we didn't know what that meant. So we decided to get a panel of about 28 markers and look into this spatial lymphocyte infiltration. And what we found was very interesting. We were able to use this the strength of this technology, which is the interaction of the immune cells within the kidney, and we were able to show that the active antigen presentation happens in kidney injury that happens in response to COVID-19. And we did this by using this computational neighborhood analysis, so we can see how close a dendritic cell or an antigen presenting cell is to an activated lymphocyte, which makes us postulate that active antigen presentation happens within the kidney rather than these lymphocytes getting activated in the draining lymph nodes and traveling back to the kidney. So this was a unique finding that was allowed by this technology. The next thing we did was we were again interested in lymphocytic infiltrates, and one sees a lot of infiltrates in patients who are treated with immune checkpoint inhibitors for different cancers. This group of drugs are associated with a lot of kidney injury, and there's a lot of lymphocytic infiltrates. So again, this technology allows itself to understand the pathophysiology underlying this immune checkpoint inhibitor mediated acute kidney injury. And once again, we were able to show that there's a lot of T cell activation within these kidneys, which is what you would expect from an immune checkpoint inhibitor, but also there's a lot of active antigen presentation and T cell proliferation within these. So this is not a innate immune response, but this is an activation of the adaptive immune responses, probably in response to the pharmaceutical treatment these patients are getting.
Thank you. So our main interest then was moving forward, as we have explained previously, to use this technique to see if we could look at the immune landscape of kidney transplant rejection. And we have previously outlined where there are limitations in terms of evaluating it from a pathologist perspective. And so we explored 32 cases of kidney transplant which had inflammation, and they included cases of T cell mediated rejection, different phenotypes of antibody mediated rejection, viral infection with BK virus, and also pyelonephritis. And we wanted to look at all of the different aspects that we could to see how we could use this technique to, in a pilot, this is a pilot study where we wanted to see where can we go with this technology and how can it really improve our understanding. So that is what we did, and this paper is published in American Journal of Transplantation. So here we show how this is a region of interest from one case, showing how single cells are labeled using a technique, and here we use the STARDIST technology to identify single cells. We then worked together to identify the thresholds for the 28 markers that were used. And once we set a threshold, which was done on a montage of images so that there was no bias, these thresholds were then applied. Now, the beauty of this technique is that a single cell can be identified not just by a single marker, but for instance, a cell may label with CD3, CD4, and CD45 row, enabling us to understand that it is in one single cell, we're able to understand that it is a memory T cell. Now, this multiplex labeling has a significant advantage. Now, once we did that, we were able to also compute the number of each individual marker that we saw. What was the percentage of that marker among all the cells that belonged to a categorical phenotype? For example, if it was a mixed rejection, a pyelonephritis, or a BK, what was the overall percentage of that single immune marker in relationship to the entire cell that was in all of the cells that were present in that disease phenotype. Now, this is how we used the multiplexed labeling first to create a tissue classifier. So when we say that, we're saying we use the markers. For example, alpha smooth muscle actin helped us identify vessels. Vimentin helped us to identify the mesangium of glomeruli. And then other markers helped us to identify the tubules. This was used to annotate over 3,000 pathology images. And then the machine learning models were tried. Different machine learning models were used to see how we could get a tissue classifier. And we had over 90% accuracy using different machine learning models, and we were able to create a tissue classifier. So the machine now can tell you, this is a glomerulus, this is a tubule, this is an interstitium. But what is the advantage of that is now you take every single cell that is present and it belongs to the center of that cell belongs to a microstructure. For example, if you take now glomerulus, which is identified here, annotated accurately both by the pathologist and the machine, we are able to now say that in the glomerulus, what is the cell that is present. So for the first time, we're able to spatially locate immune cells. Here we're focused on immune cells in relationship to glomerulus, arteries, interstitium, and tubules. And we're able to further analyze it in terms of the disease phenotype. So one can see that this is an interesting and important tool that gives us this aspect of analysis. Now, the advantage of single cells is that the power of the study is exponential. And so here, using machine learning models with a phenograph clustering tool, the single cells are analyzed and then they are clustered based on their similarity. And the machine generated 32 clusters. Of 32 clusters, there were some clusters that didn't have enough cells and they were excluded. But finally, we were able to derive, based on the clustering and our thresholding, the nature of at least 12 immune marker-based clusters and structural clusters. For example, we had clusters that were rich in memory T cells. In other clusters, we had macrophage and antigen-presenting cell-enriched clusters. Other clusters were enriched in FOXP3 positive lymphocytes. So one can see that one can now use these clusters to further analyze your tissue. So that is what we did next. What we did is we said, let's look at the immune clusters alone and let's examine the immune enrichment in the different microstructural compartments in our different disease phenotypes. And one can see that right off the bat, there is, even within a category that's been diagnosed as ABM-MAR by the pathologist using all the existing tools, there is heterogeneity in the expression of immune markers on a case-to-case basis. And this is a very important point, which brings us to a more the importance of a more precision medicine-based analysis, because we are actually treating patients in a very standardized manner, and we are not currently being able to isolate individualized tools to, I say, perhaps this patient needs something that focuses on, macrophage or NK enrichment or memory T cell enrichment. But with our technology, we now lend insight into how an individualized mechanism is perhaps possible now with this analysis. Now, this is another example of an advantage of this technique. Here is an example of interstitial inflammation, and one will recognize perhaps that these are enlarged cells which have smudgy nuclei. There's a lot of inflammation, and this is a BK positive cell. And we have used our the same region of interest, and we are showing with imaging mass cytometry the spatial association of immune cells in relationship to these BK positive tubular epithelial cells. And there has been a lot of emphasis on the role of innate immune cells in BK nephropathy, and that is supported by the presence of an enriched CD68 immune infiltrate. But one also sees that there is an enrichment of cytotoxic T cells, as seen here, and memory T cells also seem to play a role. So one sees that one can actually analyze these disease phenotypes in a more specific manner. This is an example of pyelonephritis, where one sees very beautifully the enriched aggregates of neutrophils which are expressing granzyme around tubules and within tubular lumina. In addition, one can look and see that there's a immune cell infiltrate in general, and that there is not a significant role to play with B cells or cytotoxic T cells. The other advantage of our technology was that we were able to apply neighborhood analysis, where one studies what is the association of one cluster to another. So if two clusters are frequently seen together and they interact positively, they are labeled with a large red circle and a red square. On the other hand, if they interact together but have a negative interaction, they are blue. Using this, we are able to now understand the biology of interaction in different immune phenotypes of disease. And that allows us to see, and in this diagram, we've depicted how cell clusters aggregate together and perhaps lend us insight into what is the biology and what could predict what is a poorer outcome. And we saw, using this technology, that two clusters, memory T cells when present in the initial biopsy, and if there was a high expression of cluster 12, which was co-expression of vimentin and pancytokeratin, as seen here, implying epithelial mesenchymal transformation, these clusters, when overexpressed, even in the small group of 32 cases, was able to predict a poor allograft outcome. So we are highlighting here the different aspects of this technology, which can certainly play a role in our analysis of allograft biopsies. Here we used the machine learning model to take it a step further and see if we can use it to classify diseases, so that we can train machine learning models to help us predict outcomes and predict diagnostic criteria. And we did have a great success with this technique. I'm not going into the details. One is most welcome to read this and reach out to us if you have questions, but it does emphasize the value of spatial tools. Now, when I say spatial tools here, I do not imply just its close association, but it's the ability of the machine learning model to make use of spatial technologies, such as the mean expression of a marker at the cytoplasm or in the surface or in the nucleus, and use these different technologies to predict disease outcomes. And this was done with XGBoost, the machine learning model that has the addition of what's called explainability. And we were able to use that to identify the most valuable features to differentiate different disease types. And this shows, for example, this is the expression of the spatial expression of E-cadherin, helping us to differentiate between acute T cell mediated rejection from antibody mediated rejection, just as an example. So in summary, what are the advantages of imaging mass cytometry over routine histology? It has highlighted the heterogeneity within the traditional binary rejection phenotypes. It's helped us to develop a detailed spatial map of unique clusters and highlight the relevance of these clusters in different phenotypes that are histologically categorized. We're able to use single cell derived data with clinical databases to derive biologically and prognostically relevant information. We have shown that this technology is robust even for tissues with limited biopsy material. And so it's very valuable for studying unique and esoteric disease types. And it has potential for applicability in clinical use, experimental and research models, and most certainly we hope you've seen the role it could have in biopharmaceutical industry, and certainly could play a role in relevant clinical trials where we can show direct impact of drugs targeted to specific immune groups. The disadvantages are that at the current time, it is cost and labor intensive. We work with a very sophisticated computational biology team. They are excellent. We're very glad to be associated with them, but that is certainly a limitation. And one of the challenges at the current time is that we predefined the panel of biomarkers, which imposes a limit on discovery of novel proteins, but we do know that there are ways to overcome this. And we'd like to say that AI in healthcare is certainly a way we'd like to go. Dr. Taner and I are very invested in this, and Mayo Clinic is definitely moving in that direction. And we see here healthcare leaders, Dr. Farrugia and other leaders have emphasized the importance of AI in healthcare. And with that, we'd like to thank you for your attention, and we are happy to take any questions down the line. Thank you very much.
Thank you very much.
Thank you so much, Dr. Priya and Dr. Taner, for the valuable insights. I'm just looking if there are any questions in the chat box or in the Q&A. If attendees have any questions, you can post them in the chat box or the Q&A box. Dr. Priya, what would be the cost for processing one sample of kidney tissue for this?
That's a little bit of a hard question to answer. There's no single figure. Actually, doing things in a batch works out a little cheaper. But I think we would say that it costs a little, maybe I would say $1,000, but that we can refine that and give you a better estimate if you're really serious about moving forward with this, because we see it's a moving scale since when we both started this, and now it's, you know, as we get more used to it and more markers are added. So that's
quite exorbitant for people from developing countries.
Yes, that's even for us, it's expensive. But the potential is good. So
yeah, true. Like you rightly said, it gives us a better understanding into the pathogenesis. So diagnosis, eventually helping out in early diagnosis, and finally treatment of the patient. It adds a lot of value and a lot of insights. I think there is one question in the box from Dr. Arpita. She says, are you able to differentiate C4D negative ABMR with the IMC with knowledge currently available with you, or a mixed ABMR and TCMR?
That's a great question. And we are actually looking at that. That was not part of our cohort. We didn't look at C4D negative ABMR in this study. So we cannot answer that question. However, there have been some recent studies using spatial profiling that have looked at that very recently, and we ourselves are going to try to address this very important question ourselves. That's our next step. So we certainly hope we'll be able to give you more answers, but with other studies that have been done similarly with not as complex spatial markers, one group has shown that there's more of T cell profiling in patients who are C4D negative ABMR. So that's just an initial insight into that topic.
Hope that answers your question, Dr. Arpita. Any other questions in the chat box, please? I don't think there are any more questions. Thank you for your wonderful talk, Dr. Taner and Dr. Priya Alexander. Your insights and the presentation were very enlightening, and we really appreciate the depth of knowledge that you shared with all of us. And it was very engaging and informative as well. Thank you for taking time to share your expertise with all of us. On this International Women's Day, it is actually a proud moment for all of us to witness Dr. Priya's amazing work and exceptional achievements. You are truly an inspiration for all of us, especially women in nephrology India. Your dedication and contribution has been amazing. Thank you for paving the way for all of us, being an inspiration for all youngsters like us. Thank you so much. Thank you, Dr. Taner. Thank you, Dr. Priya.
Thank you. Those are very kind.
Thank you very much for the kind invitation.
Have a good day.
Thank you. Bye. See you.